Hello, we're beginning Chapter 9. This is going to be on armamentarium that you'll be using when you deliver local anesthesia. So I'm going to start off by showing you the picture. This is when last week when Frankie met his new brother Hudson, and I thought it was an appropriate slide to show because I'm going to show you a close-up of Frankie's face, and he was not really excited. He certainly wasn't as excited as everyone else was. He was a little unsure, and as I cover more and more of the material in this course, you're going to find that it starts becoming more clinically relevant, and it's not unusual and in fact should be expected that you feel a little bit unsure as to how to handle this armamentarium and to be actually administering local anesthesia. So I'm going to end the chapter by showing you how he felt about his brother 2 or 3 hours after he had been in the house for a little while. So I'll end this lecture with a picture that's a little more promising than this one may be. But anyway, so we're going to start off talking about the armamentarium, and before we get there I want to talk about some terminology. These 3 terms are words you're going to hear me say over and over and over again. You have to know what they mean. You have to know what I'm talking about. You should be able to picture in your mind's eye what we're talking about when these terms are used. An aspiration test is when you apply negative pressure within the carpule of the syringe, and it's done to determine whether or not the needle is within a blood vessel. Now, one of the things that contributes to local anesthetic causing toxicity is injecting directly into a blood vessel. And so when you are administering local anesthesia, when you get to your target site where you plan on, as I call it, dumping your load, where you plan on delivering all this volume of local anesthetic, you're going to perform an aspiration test, and you're going to pull back on the syringe, on the thumb ring of the syringe, which will create negative pressure. If you get a positive aspiration, that means that you're going to get a little bit of blood that comes into the syringe. Now, if you've ever had an IV started, that's one of the, and you've watched, I don't watch, but if you've watched, one of the things the nurses will do to check to see if they're in a blood vessel is an aspiration test, and they pull back, and if they're in the blood vessel, then they'll push down the cannula and they'll start their IV there, but they have to make sure that they're in the blood vessel. What we want to do when we perform that aspiration test is we want it to be negative, because we don't want to put local anesthetic directly into a blood vessel. So if you get a positive aspiration, you're simply going to move the needle backward just a little bit, about 1 millimeter. These vessels are pretty small. So you back up just a little bit and you'll aspirate again. But when we're talking about aspiration, it means creating a negative pressure within the syringe so that you can determine whether or not you're in a blood vessel. And we want a negative aspiration before we deliver the local anesthetic. And we'll cover that under technique in the next chapter. The bevel is the part of the needle that is angled, and it is because it's angled that the needle is sharp, that it has a tip. Within that angled surface, when you look at a needle, you'll see a tiny hole, and that's where the anesthetic comes out, is through the bevel. Okay, and the bevel's really important because you want to make sure that you line the bevel up in certain positions based on the type of injection you're giving. And we'll talk about that as we go through the technique for each individual injection. But you need to understand that the bevel is going to be the flat surface of the needle. And unfortunately, I don't have you with me, and normally when I give this lecture, you have a needle in your hand and you have a syringe in your hand, and so you're able to make it make sense instead of just looking at pictures and listening to me drone on and on and on. But I have arranged time when you come back, hopefully the first day you're back, during orientation. I'm going to get you in 2 separate groups, and I'll pass out the syringes and the needles, and you'll actually be able to put a syringe together to look at the needle, look at the carpules, load a syringe. We're going to have you do an aspiration test. So you'll actually get your hands on this armamentarium, on this equipment. It'll make a little more sense. Gauge refers to the diameter of a needle, and it's actually backwards from what you would think. You would think that a 30 gauge needle would be bigger than an 18 gauge needle because it's a bigger number. The number of the gauge, and the number indicates the diameter, but it's an inverse relationship. So an 18 gauge needle looks like a roofing nail, okay? And a 25 or a 30 gauge needle looks like a sewing needle, much, much thinner, much smaller. So the larger the number when we're talking about gauge, the smaller the diameter. All right, so a 25 gauge needle has a larger diameter. It's a bigger needle than a 30 gauge needle, okay? So the main components that you're going to be using when you deliver local anesthetic is going to be the syringe, and it is an aspirating syringe because you have to aspirate before you deliver your local anesthetic. A needle, and they're all disposable. You're only used on one patient, and it's referred to as a hypodermic needle because you inject with it. And a single dose cartridge or carpule of local anesthetic, which may or may not have epinephrine in it. When we deliver local anesthesia and do these injections on each other, we will be using plain anesthetic, so there won't be epinephrine in them. Additionally, you will need and you will use topical anesthetic. You'll need an applicator stick to apply your topical. You'll need gauze. The gauze is used to dry the tissue before you apply the topical. You get a little better absorption onto a dry surface. The gauze can also be used to retract the lip so that the lip doesn't slip out of your fingers, or retract the cheek so that it doesn't slip while you're delivering anesthesia. So gauze is always a good thing to have around. Cotton pliers or hemostats you want to have in case, heaven forbid, that the needle breaks, but that would be used for needle retrieval. Or more commonly, the rubber stopper at the end of a cartridge or carpule gets stuck in the syringe and you have to remove it. Well, that's a contaminated piece of equipment, so you don't want to handle it with your fingers. You're also likely to stick yourself with the harpoon of the syringe, so you always use cotton pliers or hemostats. And then a needle shield or some sort of recapping device. Most exposures following local anesthetic are made during needle recapping. So you always want to have a shield or some sort of recapping device. And here at the dental school we use shields. We just use a piece of cardboard. So these are the components of the syringe, and I'm going to go through each one individually. Important part is the needle adapter, and it's the butt end of the syringe. actually can unscrew. It can come off. And I tell you this because if when you unscrew the needle and you throw this end of the syringe away, the syringe can't be used again and you're going to be charged for it. So pay attention and make sure when you unscrew the needle that this metal needle adapter is not attached to the hub of the needle. Okay, it's not attached to the needle. And then the syringe barrel, you're going to hear me talk a lot about the barrel. It makes up the bulk of the syringe, and I'll talk to you about which way to move the barrel and how to align the barrel. So that's what we're talking about, is this portion of the syringe right here. The harpoon is a sharp end of the piston, which is this piece right here. The piston connects to the thumb ring. It screws in, it goes through the finger grip into the thumb ring. And you put your thumb through this hole, and that is going to allow you to push the piston into, put pressure on it, which will expel the contents of the carpule when you have a needle attached. It's also by pulling back, by pulling back on the thumb ring that you perform your aspiration test. That creates a negative pressure. But for that to happen, you have to engage the harpoon into the rubber stopper of the carpule. Okay? So I'm going to go through each of the, and then in between you have all these parts and pieces. But I'm going to go through each of these components so that you'll know what they are. So the needle adapter I've already talked about. You'll take the needle and attach it to the needle adapter by twisting in a clockwise motion. To take it off, you'll go counterclockwise. The syringe barrel is this portion right here, which is in between the needle adapter, which is that threaded end, and the finger grip, which is right here where you put your fingers. The barrel has a small window and a large window. You'll use the large window to drop the carpule into the barrel of the syringe. The small window is used because sometimes the barrel is twisted in such a way that you cannot see the contents of the carpule, and you can't see the large window. And so the small window will allow you to see if blood enters the carpule if you have a positive aspiration. You ideally want the large window facing you so that you can see how fast you're injecting and whether or not when you aspirate you see blood enter into the carpule. The harpoon is this sharp end that's at the end of the piston. It's the terminal end of the piston, and it is embedded into the rubber stopper. And it allows you, it's only after you have engaged this harpoon into the rubber stopper that you can perform an aspiration test, or you can expel the contents of the carpule. The piston is this entire length, this rod that has the harpoon on one end. It screws into the thumb ring, but only after it passes through the guide gear, the spring, and the finger grip. So all of this is put together when you check it out. It looks like this. Okay, it's all been put together. I will tell you that sometimes you need to tighten up the thumb ring into the piston. Sometimes they can get loose. The spring is located inside the gear and inside the finger grip. But what it does is it allows the piston to be pulled back, to be pulled backwards, which allows you to load the cartridge into the syringe barrel. and it also allows you to perform an aspiration test. So the spring is important for loading and unloading the cartridge and for performing aspiration. The finger grip can either have wings, these are wings, or it can be wingless, meaning it doesn't have these extensions. It comes down to personal preference, and whichever feels better in your hand, you can let your doctor know, and they'll be more than happy to order you syringes that you're comfortable using. But the importance of the finger grip is that it allows you to control where the syringe moves, and it gives you stability of the syringe. The syringe is resting in your fingers. It really doesn't rest in the palm of your hand or in your thumb. It's those fingers that are carrying the weight of the syringe. It's important, and I'll show you this when we have the session where you actually handle a syringe. You want to place the syringe in between your index finger and your middle finger rather than in between your middle finger and your ring finger. And if you start off learning how to use a syringe that way, then that frees up your ring finger for fulcruming so that you can get a finger rest, which is really important to prevent the syringe from shaking. You know, it gets rid of your tremors. So you want to put the finger grip in between your index and middle fingers. The thumb ring attaches to the piston, and the harpoon's here at the terminal end of the piston. It allows you to control that piston and the spring within the gear, within the finger grip, so that you can retract when you're loading and unloading the cartridge, as well as for aspiration. And it also allows you to control how quickly you're emptying the contents of that carpule into the tissue. So by putting pressure on that thumb ring, it will advance the piston, which expels the local anesthetic. Now these are made in different sizes. You'll notice that the size of the barrel of the syringe is the same, but that the thumb rings are different sizes. If you have really tiny hands, really small hands, you're probably going to need a small syringe. We don't have them available in the clinic, unfortunately. But if you have trouble getting your thumb into the thumb ring because your hands are so small, and you'll know when you get your hands on a syringe whether or not you're going to have problems, you'll know that you'll need to have your doc order the small size thumb ring. And some guys need large thumb rings. I worked with a student, gosh, it's been 6 or 7 years ago, a dental student who was a U of L was on the U of L football team, and he was a lineman, and his hands looked like a baseball mitt, and he couldn't even get his thumb into the thumb ring of a traditional regular sized syringe. It was amazing how big his fingers were. I don't know how he ever worked on children. I bet he had a fit up in the pediatric clinic trying to get his big hands in such a small mouth. But be aware that you can get different size thumb rings, which will make it easier to control the piston when you get out in practice. There are several different types of syringes that are available. Over 90% of offices use the reusable metallic aspirating syringe. They last years and years and years and years, as long as you don't throw away the needle adapter. The syringe that I use to demonstrate, and I will show you in class, I've been using over 35 years, and it's still fine. So they're very, very hardy syringes. There's also a reusable metallic self-aspirating syringe, which sounds like a great idea. People that like them really like them. I never liked them. If you get an opportunity to use one, I would certainly try it, see if you like it. There's a lot of movement that you have to do with your thumb to get it to aspirate. The syringe doesn't magically aspirate by itself, but I'll show you how that works here in a minute. You can also get plastic aspirating syringes. There's a special syringe that's used for a PDL injection. I'm going to show you a little bit about the jet injector, which is the needleless, no needle syringe, as well as the C-clad, and I'll also show you disposable safety syringes, which are available, although they're rather expensive. So this is a reusable metallic aspirating syringe. It may or may not have wings. Some of them in our clinics have wings, some don't. It lasts for a really, really long time. The disadvantages include that it's heavy, it's difficult if you have really small hands, and you have to be careful about making sure that this harpoon is engaged completely into the rubber stopper, because otherwise you go to aspirate, and if the rubber stopper doesn't pull backwards, then you don't create negative pressure and you don't know whether or not you're in a blood vessel. So that can be a problem. A reusable metallic self-aspirating syringe looks a lot like aspirating syringe, except that it does not have a harpoon. At the end of the piston, it's a flat butt end, and the only advantage is that you don't have to, or really the only advantage from an aspirating syringe is you don't have to engage the harpoon, which can, until you learn how to do it properly, it can be that can be a problem. What you have to do when you use this to get it to aspirate, and it's available with a thumb ring and without, even though this is still called the thumb ring, it's thumb rest. What you have to do when you get to target is you have to take your thumb out of the thumb ring and put it on this disc, and you push down on the disc, and that's what performs the aspiration for you. But taking your thumb out of the thumb ring and putting all the weight and the control on the finger rest, the finger grip, oftentimes will cause that needle to wobble and you lose control, and that's why most operators don't use it. You tend to have more control with an aspirating syringe, but like anything else, you can get really good at using it. So if it's the only syringes that your office has, you'll learn to love it, I'm sure. I've never been a fan, but the reason is I haven't used them. So there are also plastic aspirating syringes that are reusable, meaning that they can be autoclaved. One of the more obvious disadvantages is that it can discolor over time, and so it looks dirty, and so it tends to not, people tend to not use it as much. It looks dirty even though it's not. A pressure type syringe, or PDL syringe, is used for intraligamentary injections, and that's where you inject directly into the PDL, the periodontal ligament, of a single tooth, and it will anesthetize a single tooth. You have to put a lot of pressure on the needle to get it to go into the ligament, and it's really hard to inject to deliver your local anesthetic because that's a tight space. You have to take the needle, you go through the junctional epithelium, you go through your connective tissue attachment, your biologic width, you go into where the tooth root and the bone meet, where that periodontal ligament is, and you have to force the tip of the needle into that ligament. And then you deliver just a little bit of local anesthetic. It will anesthetize a single tooth. It's difficult to deliver the anesthetic because it's so tight, and a PDL syringe will administer 0.2 mLs with a squeeze of this trigger. And it just clicks, and usually a couple of clicks, and you'll have enough anesthetic to anesthetize that tooth. It is under a lot of pressure, and it can cause tissue trauma. These syringes are also expensive, and because of that, and because you can give a PDL injection with a traditional aspirating syringe, generally offices just use a regular aspirating syringe, and these are not available a lot. They're great syringes, and they're nice if you give a lot of PDL injections. The jet injector is a needleless syringe. It doesn't use needles. It really was it was the thing back about 10 years ago. Oh gosh, maybe it's been 15 years now. Because people are scared of needles. They don't want needles. It will deliver between 0.05 to 0.2 milliliters of anesthetic, so you can measure the dose that you deliver. It delivers that local anesthetic under a high pressure, and it's kind of like if you've ever heard an air compressor, the hissing sound. When you deliver the dose, it gives off that hissing sound, and there's a big puff pressure that is expelled with it up to 2,000 psi, which is a bunch. It's a lot. And oftentimes that will really startle patients. You have to give them the heads up. You're going to hear, a hissing sound. You're going to feel pressure. The reason it's an expensive piece of equipment, and the reason it's really not used, is it only provides soft tissue anesthesia. So it doesn't do anything more that topical applied with a cotton tip applicator does. So it was, although having said that, occasionally you can get anesthesia in children on the maxilla. But again, the hissing sound, the pressure is startling, and it really is not much in vogue. I don't know anyone that's ever used them routinely, but be aware that it is out there, and it is an option for you. The CCLAD, which stands for Computer Controlled Local Anesthetic Delivery Device, also called the WAND, is a tremendous tool if your office has one. It provides pulpal anesthesia for one tooth at a time. It's very, very lightweight. It is expensive. It costs over $2,000 now, I believe. It gives you a precise control flow. You'll learn with time, using an aspirating syringe, how to slowly inject a patient. But it takes time to develop that. And this CCLAD delivers one drop every other second, which that flow rate is pretty much painless. Because it's so small and it's so lightweight, you don't get hand fatigue. And you're only injecting a tooth at a time. You actually rotate the needle into the bone, which allows you to have a more accurate deposition of the target site. So this is what it looks like. Very, very, it's a wonderful tool. Wonderful tool. If you're fortunate enough to have it available in your office. And then this is what disposable safety syringes look like. They're preloaded. The needles are covered, and when you get ready to use it, the needle cap retracts over the barrel, and then once you've used it, that needle cap pops back up and shields the needle. It decreases the risk of accidental exposure. These are not really cost efficient. They're expensive. They're expensive to use. So for the most part, they're used in very, very specific circumstances, maybe on mission trips or something like that, where you don't have access to autoclave, or you can't autoclave your syringes. That would be a great use for disposable safety syringes. So here's Frankie. He's now gotten a little bit closer to Hudson, and hopefully you're feeling a little less hesitant about the whole injection process. We gave Frankie a gift to open. He was opening up. It had 3 cars in it, and he was actually tolerant enough of his brother to, when he opened up his cars, there were 3. He only has 2 hands, so he kind of threw one towards Hudson and decided that Hudson could have one of his cars, which we thought was a pretty positive sign. And so that's a good thing, and hopefully you're feeling a little less apprehensive about the whole injection thing. So we've talked about syringes. Now we're going to talk about needles. All needles that are used in dentistry today are stainless steel. They're pre-sterilized, so when you get the needle, it's already been sterilized, and it's disposable. It's used for a single patient, not a single injection. You can reuse a needle on a patient 3 to 5 times, but you don't really want to use it more than that because the bevel becomes dull. The needle becomes dulled by repeated insertions. The parts of the needle include the bevel, which is this slanted tip terminal end of the needle, the shaft, which extends from the tip of the needle all the way to the other end. This is the end of the needle that will actually be put into the carpule. The hub, which is located right here, and the hub is where the shaft meets the needle adapter, and that's what this white thing is. Now, the needle adapters that we use in our clinic are aluminum, so but it'll look the same way. And then you have the carpule penetrating end of the needle, which is the first portion of the needle that you will actually insert into the carpule, and then you'll screw down the needle adapter. So the bevel is the angled surface of the tip of the needle, which is not, this is the carpule penetrating end, but you can see the bevel there. The bevel that we're talking about is at the other end, and some needles have a stamped ink mark in the shape of an arrow that shows you where the bevel is on the needle, and that's significant if your needles have that, because if they don't, you're going to find yourself holding the syringe up and twisting it around looking for the bevel of the needle. You have to reflect light off of it to actually find it, and you have to orient the bevel of the needle in certain positions based on the type of injection you're giving. So it's really nice if you have an ink mark to show you where the bevel is on the needle. The shaft is from the tip of the needle all the way to the end of the carpule penetrating end. It's the entire length of the needle. It's very rare for a needle to break, but it can. If a breakage occurs, it's almost always because you've put too much pressure on the needle, or you've got sudden patient movement, patient jumps or jerks, or grabs your hand, heaven forbid, while you have a syringe in their mouth, a needle in their mouth. Or if you insert the needle all the way to the hub, because that's the weakest point. So those are the things that can contribute to a needle breaking. And then the components of the shaft of the needle are going to include the gauge, which will tell you the diameter of the needle, as well as the length, which will tell you how long the needle is. So the hub and the needle adapter are one piece. And it is used to attach the needle to the syringe, to the needle adapter of the syringe, the terminal end of the syringe. It can be aluminum or plastic. We have aluminum in the clinic now. And you can move that needle adapter so that you can change the orientation of the bevel of the needle. Okay? If it's marked with an ink mark, that's great. The carpule penetrating end is this end of the needle. It actually is pushed into the carpule. It's placed after the carpule's loaded and the harpoon's engaged, and it is the first piece of plastic that comes off of a pre-sterilized needle. So you can't take the cap off. You have to take the carpule penetrating end off first. Okay, and it's clear. So I'll show you what that looks like here in a minute. There are 3 gauges that are used in dentistry for intraoral injections: a 25 gauge, a 27 gauge, and a 30 gauge. Keeping in mind, the larger the number of the gauge, the smaller the diameter of the needle. So a 30 gauge needle is thinner and has a smaller diameter than a 25 gauge. Which gauge you choose is based on how deep, how far into tissue you have to go, and how likely it is that you're going to encounter a blood vessel. If you're going into a really vascular area, you want to use a larger diameter needle because you get more reliable aspiration the larger the diameter. So it's important for you to understand, because you're going to feel, and patients will think, and some older dentists will tell you, that a 30 gauge needle, because it's a smaller diameter, causes less patient discomfort. Scientific based research has shown, it's been repeatedly proven, that if you blindfold the patient and you inject them with a 30 gauge or with a 25 gauge intraorally, they cannot feel the difference. They can't feel the difference. That's not true with skin. Okay? If someone is using a 30 gauge versus, well, they're not going to use a 30 gauge. Well, they could with diabetes. But the smaller diameter, you don't feel as much on the skin as the larger diameter needles. But that is not true intraorally. Patients cannot feel the difference. So choose the gauge that you need based on what you're using that needle for, and don't think about patient comfort. Advantages of using a 25 gauge needle, the larger diameter needle. There are 6 advantages. You need to know those. I'm telling you right now, you need to know them. There's a decreased chance of deflection. And what that means is, as you go through tissue, if you go through muscle, you're less likely to have the needle bend going through muscle, because it's a larger diameter needle, and just like anything else, the larger diameter is going to be stronger. You're going to get less movement. There's a greater accuracy of target location with a 25 gauge versus a 27 or 30 gauge, because of the same reason. You get less deflection, less movement. They're more rigid. That means they're less likely to break. You get more reliable aspiration. That's a big reason to use a 25 gauge. Because of all of these things, 1 through 4, there's an increased success in gaining anesthesia when you use 25 gauge. And because of 1 through 4, you're less likely to have needle breakage. There are 2 needle lengths commonly used in dentistry. Not commonly, that should be an N. Long and short. A long needle is 32 millimeters long. A short needle is 20 millimeters long. The needle length that you choose is based on the amount of tissue you have to penetrate to get to your target. So we'll teach you which length you need for which injections. Generally, a needle should never be inserted to the hub unless it's necessary for a successful injection. So general rule of thumb is don't go to the hub. When I'm working with you all, you're going to hear me say, go, 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 keep going, and you're going to say, but I'm almost to the hub. And that's okay. If you haven't gotten to where you need to be, it's okay to go to the hub. You just want to go slowly. And you only go to the hub if it's necessary for the successful injection. You always must use a long needle for a mandibular block. It is not safe to use a 30 gauge needle for a mandibular block. You may work for a dentist that uses a 30 gauge needle for a mandibular block. You know better. Don't do it. Don't do it. Okay? You're more likely to miss a block because you can't get deep enough. And if you run into problems, if the patient jerks and something happens and that needle breaks, a 30 gauge needle breaks giving a mandibular block, you're going to lose in any court of law, period. That's your fault. Because I'm telling you, you do not use a 30 gauge short needle for a mandibular block. You have to use a long needle. They do make an ultra short 30 gauge ultra short, which is sometimes used for infiltrating for hemostasis. It's a fine needle to use for that, and it's sometimes used for palatal injections, and it's fine to use for that. But for the most part, we use short and long. Short is available in 30 gauge and 27 gauge. And they have a blue and an orange needle color cap, needle cover. And then your long needle lengths are yellow and red capped. 27 long is yellow and a 25 long is red. Okay, so they are color coded. Always, you never, ever, ever reuse a needle and go from one patient to another, so it's only used for one patient. The plastic cap or shield should remain over that needle until you're ready to inject and should be replaced immediately upon injecting. You can re-inject a patient with the same needle 3 or 4 times. I wouldn't go more than 3 or 4 times without replacing the needle because it dulls the tip and it becomes uncomfortable when you penetrate. You always want to recap the needle, the plastic shield or cap. You want to use only one hand when you recap, and I'm going to make you take your non-dominant hand. For most of you, it will be your left hand. But you take your non-dominant hand and put it behind your back and learn how to recap your needle with your non-dominant hand behind your back so that you learn how to recap only using one hand. You have to know where an uncovered needle is at all times, so make sure that you don't stick someone in the leg or in the arm or in the hand when you're, don't sling them around and fling them around. a needle around, a syringe around, if it's not covered. You shouldn't do that anyway. If the needle becomes contaminated, recap it and dispose of it and replace the needle. It's pretty hard to believe I would have to say this, but I do because it did happen. A student was injecting, getting ready to inject a partner, and as she was going into the mouth, she stuck herself. She accidentally stuck herself. That's a contaminated needle. At that point, she should have come out, replaced the needle. That's not an exposure for the student that was injecting because it was a clean needle. But she should have come out, washed her hands, put a new glove on, replaced the needle. Instead, after sticking herself, she then injected the patient, the student partner. So the student partner then had an exposure. Okay? Because the patient, the student that was the patient, was injected with a contaminated needle. So if a needle becomes contaminated, you stop, recap it, and dispose of it, and get a clean needle. Now, that same thing could happen if you go to inject the patient and you accidentally scrape the needle against equipment, against the bracket table, or it touches something. It's contaminated. You don't then put that in a patient's mouth, okay? So if a needle becomes contaminated, recap it, and then you dispose of it in a sharps container. You don't put needles, even contaminated needles, in the trash can. They always go in a sharps container. So this is the proper way to recap. In private practice, you're probably going to have one of these nifty little devices that you just line up your needle directly over the needle cap, and it goes right in it. These tend to disappear from clinics, so we don't use them. We use the cardboard, which is fine. It works just as well. But the important thing is to recap with only one hand, because if you grab a hold, if you grab this cardboard with your other hand and you slip, the needle can go in between the cap and the cardboard around here, and you can stick yourself, or you can just miss the cap entirely and end up sticking yourself and having an exposure where you're holding the cardboard. So you don't hold the cardboard. You don't use your non-dominant hand at all. So if you're a left-hander, you're doing all this with your left hand. If you're a right-hander, you're doing this with your right hand, and your left hand doesn't come into play. Potential needle problems: pain on insertions, usually due to a dull needle, or you haven't allowed 1 to 2 minutes for topical to go deep enough into the tissue. If you have pain on withdrawal, if a patient's uncomfortable when you're pulling the needle out, it could be that the tip has a barb on it, and that can occur if you hit bone really hard. Now, I'm going to talk to you as we do some types of injections, about bumping the bone. And bumping the bone means you don't crash into it. You just gently come in contact with bone. And there's certain injections that you have to know where the bone is. So you have to find it before you inject. So you don't want to be pushing the needle through tissue really rapidly that would allow the tip of the needle to forcefully contact the bone. And rarely but occasionally you can get a barb in manufacturing. An exposure is when a clinician has a needle stick with a contaminated needle that's been used in a patient's mouth, usually due to two-handed recapping. Can occur if the patient moves unexpectedly or when you're taking the needle off. There's some other times that it can occur, but most often it's from recapping a needle with using two hands. If you use a mouth mirror to retract instead of your fingers, you're less likely to have a needle stick exposure because your fingers are out of the way. And I'm going to teach you how to use the one-handed scoop method. Needles can break. You should never, ever, ever bend a needle prior to injecting. And you may have doctors that say, oh, we'll just bend the needle. Don't do it. When you bend the shaft of that needle, you're weakening the needle. And if a needle breaks because you bend it, I guarantee you in a court of law, you're going to lose. You should never, ever bend a needle. There is an exception. The exception's if you're giving a periodontal ligament injection in the posterior. You have to bend it. But that's not injecting into tissue, and it's not giving block anesthesia, which is what I'm going to be teaching you to do in this course. So don't bend a needle. Sometimes when you retract and you pull a needle out, you'll see that it has a bend on it. That's okay. You didn't bend it. That can happen. That's what I'm talking about when I say a needle can deflect. That's deflection. If you have a needle that is bent, you want to replace it before you use that needle again, because it's now, that shaft is weakened. And again, the only acceptable reason to bend a needle is if you're giving a periodontal ligament injection. A sudden direction change, and you can do that with a mandibular block. If the needle is too far in tissue and you change directions, too great a direction change, that can cause a needle to break. And so I'm going to teach you how to do that without bending the needle or causing needle breakage. And really with a 25 gauge you're pretty safe. That's a pretty hardy strong needle. Forcing a needle against resistance. If you meet resistance, you want to withdraw and redirect. Don't keep pushing because it has nowhere to go, and that can cause needle breakage. The hub is the weakest point of the needle. You need to know that. That's going to be on every board exam you take. What is the weakest part of a needle? It's always the hub. And inserting a needle all the way to the hub increases the chance that a needle will break, because you now have that needle all the way buried in tissue. There are times it's okay to go to the hub, but only with a 25 gauge. Okay. 30 gauge needles, almost all needle breakages occur with a 30 gauge needle, period. Period. Unless you're really not paying attention, or a patient reaches up and grabs your hand or turns their head at 45 degrees, a 25 gauge needle is not going to break. It's too strong, it's too rigid. But a 30 gauge needle will. So you better respect that and keep that in mind if you choose to use the 30 gauge. Now, there are times certainly on the palate it's okay to use the 30 gauge. We don't use them. I'm going to teach you to use a 27 and a 25 gauge because you can't get reliable aspiration with the 30 gauge. You can be smack dab in the middle of a blood vessel and not know it because you aspirate and you get no blood because the needle's so small, blood won't enter the carpule. So it's unreliable aspiration. Keep that in mind if you choose to use a 30 gauge needle. Talk a little bit about carpules. We've been talking about anesthetic. In Chapter 5, we talked about all the different types of anesthetics that are available. And I talked about carpules and 1.7 milliliters to 1.8 milliliters of solution in each carpule. carpule may have 2%, 3%, or 4% local anesthetic agent. These carpules or cartridges are packaged in what's called a blister pack that has 5 to 10 carpules per package. You want to store them in a dark place at room temperature in the original container. They shouldn't be taken out and stored in a drawer, although sometimes they are. I know they are. They really should not. The local anesthetic and the solution is contained within a glass cartridge. Carpules are made of glass. It's a single-use dose only for one patient. The rubber stopper should be slightly indented. So there should be space between the end of the cartridge or carpule and the rubber stopper. You should see a little bit of space. If you don't see that space, if the rubber stopper isn't slightly indented, then that cartridge has been contaminated and you need to discard it. You shouldn't use it. The end, you have a rubber stopper end of the carpule, and on the other end is a diaphragm or a thin membrane. That membrane is permeable, and in fact that's where you're going to put the carpule penetrating end of the needle, through that membrane. But if you take the carpule and you put it in a disinfectant, like some sort of disinfecting solution, that solution is going to be absorbed into the cartridge, into the carpule, and will become contaminated. So if for some reason the cartridge or carpule becomes contaminated, you drop it, or I don't know, it rubs up against something, take a cotton gauze with disinfectant on it and just wipe it across the carpule penetrating end. On a carpule, your carpule is going to be labeled, and it will include both the trade name and generic name of the drug that's within the carpule. It will include the concentration as a percent. It'll say 2% mepivacaine, 2% marcaine, whatever. 4%, 2% marcaine. It will tell you the vasoconstrictor dilution, so it'll say 1 to 50,000 epinephrine or 1 to 100,000 epinephrine, or 1 to 20,000 levonorepinephrine. It'll have an expiration date and a lot number. You need to always check the expiration date, and you would check the lot number if for some reason a drug is being recalled. It'll be recalled by lot numbers. The manufacturer's name will be on there in a color-coded band. So this is what they look like. This is the blister pack, and you peel this paper back, and usually there are 10 carpules in there. They're color-coded. You see here bupivacaine, hydrochloride, 0.5%. So it's going to have the drug. It's going to have the identifying color. It will also have an expiration date. It'll tell you the milliliters here, 1.7 milliliters. Be aware it might be 1.8. So it's going to have all this information, and you'll be able to actually handle and look at the cartridges in August when we meet again. Cartridges can have problems. It's common to have a small bubble, like 1 to 2 millimeters in diameter, within a carpule, and that's harmless. It doesn't matter. If you have a bubble that's larger than 2 millimeters, that means that the anesthetic in the solution has either been frozen or contaminated. So this is a small bubble. This is too big a bubble. So you always inspect your carpules before you load them. Look at them. Make sure that they're not expired. You want to look at the rubber stopper. This is an extruded rubber stopper because it's even with the end of the cartridge. This little piece of glass that you see, that's a normal stopper. That's what it should look like. If the stopper is all the way even with the end of the carpule, you got to throw it away. That's a contaminated extruded rubber stopper. It can happen if the solution becomes frozen or if you soak it in a disinfectant. The cap, and the cap is, we're talking about this end, and it's where the membrane is located within this cap. If the cap has white debris on it, that means it's either been soaked in cold sterilization or it's somehow contaminated. You want to throw that away, discard the carpule, don't use it. If there's rust on the cap, that can happen if a carpule within the blister pack breaks, and it will rust, so that's contaminated, throw it away. If a cartridge, obviously if a carpule's broken, you don't want to use it. When you're engaging the harpoon, if you put too much pressure on the piston in the process of engaging the harpoon, you can break a carpule, the glass cartridge, and if that happens, you throw it away. You don't use it. Clearly, you wouldn't use it. And I'll show you how that can happen in August, when we're actually handling these things. Burning on injection can be caused by, and we've already talked about, a low pH, that the acidity of the solution, particularly if there's a vasoconstrictor in it, and that's normal, and there isn't anything you can do about that. That tends to be more, you tend to be more sensitive in the anterior regions of the mouth, so you're more likely to get burning anteriorly. There used to be a thing where, and maybe you'll work in an office that has it, where the carpules can be heated. If you get them too hot, that will cause burning on injection. And really, carpules should be injected at room temperature. I used to work, I only worked Mondays through Thursdays, and we took Fridays off. And in the wintertime, I would have the heat kick off. And in Bluefield, you get pretty cold winters. They average about 100 inches of snow a year, so a winter. So it's cold. It's in the mountains. And we'd come in on Monday morning, and if I had to give injections, the syringes were cold, the instruments were cold, and the carpules were cold. Certainly not warm enough to be room temperature. And so you can bring a carpule to warm temperature by running the syringe with a loaded carpule under warm water, or just taking the cartridge and rolling it in between your hands with friction. That'll warm it up. So you want it at room temperature, a little bit warm, but if you overheat them, that'll cause burning on injection. If you are using an expired local anesthetic, it will burn. So always check your expiration date, discard if it's past the expiration date, and if that carpule has been contaminated. In addition to with the disinfectant, if you soak it in Cidex or something like that. In addition to contaminating the carpule, if you inject a disinfectant into the soft tissues, it can cause edema, and it can even cause paresthesia, where a person remains numb for a long period of time or even forever. So you don't ever place carpules in disinfecting solution, ever. If you need to wipe one off, you get a piece of gauze and you wipe it down, but you don't ever soak it in a solution. So this goes through how to load a syringe. I have loaded a video under the Monday morning meetings under Collaborate, Blackboard Collaborate. You can go on there. I've loaded lots of videos, 5, I believe, videos, and one of them is Armamentarium. And so you can click on that, go into Collaborate, click on that video, and it's going to walk you through the process of loading a syringe. I'm not going to go through and read all of these slides, but you're going to check your cartridge, You're going to wipe it only if it's necessary, only if for some reason it becomes contaminated. Retract the piston. You do that by pulling back. Insert your carpule stopper end first into the barrel. You're going to engage the harpoon, and you're going to look at where the harpoon meets the rubber stopper. And if you can still see the harpoon, then it's not engaged. So you want that flush or almost flush. Okay? If you really bear down on that and crank down on that thumb ring, keep in mind this is glass, and you can break that glass carpule, so you don't want to use extreme force. You're then going to take the clear plastic end off the needle. You twist that to break the seal, and you push and twist clockwise to engage the needle into the syringe. It will penetrate the cap of the carpule and will then attach to the needle adapter. You then want to take the cap off of the needle and squeeze and make sure that a little bit of anesthetic comes out. Just to make sure that before you, what you don't want to do is go in the mouth, go get to your target, and then go to inject and find out that this anesthetic solution won't come out. You can't get it to come out through the needle. So you always check your flow. And then you recap the needle using a one-handed scoop method. And you're ready to go into the mouth, give your injection. When you go to dispose of, when you're done giving the injection and you go to dispose of the cartridge, the carpule, and the needle go in the sharps container. The cardboard needle protector doesn't go in this box. That goes in the trash can. So you take the needle protector off first, and you go to the sharps container. Don't be walking around. Don't unscrew the needle and then walk around with a free needle end. The other thing you don't want to do is recap the penetrating end of the needle, because there's no way to safely recap it. So you walk your syringe to the sharps container. Unscrew the needle. Make sure that that metal needle adapter isn't attached to it. And drop the needle into the sharps container. This is the needle adapter. You don't want that. You don't want to throw that away, or you just bought a syringe. Don't disengage it with your fingers, because you can have an exposure. You can stick yourself, because this carpule penetrating end is as sharp as the needle tip end, and it's contaminated once you've injected someone. So use hemostats or cotton pliers to get this metal piece off if it is attached. After you've thrown the needle away, you're going to take the carpule out. You retract the piston, take the carpule out, and you put the carpule in the sharps container as well. If the rubber stopper remains on the harpoon, then you don't use your fingers, but get cotton pliers or a hemostat and remove the rubber stopper, and the rubber stopper goes in the sharps container as well. When that happens, you know you were really well engaged. That means your harpoon was where it was supposed to be. Okay? So that is the end of this lecture. And I'm going to hopefully put a smile on your face, because this was taken about 3 hours after Frankie had had a chance to get to know Hudson. And it didn't take long for him to realize that he wasn't as intimidating and as scary as he looked, even being as little as he is. It's kind of scary to see a newborn baby. And of course now he can't keep his hands off of him. Our biggest concern is that he's gonna hurt him. But I hope that as you go through this information, and as you look at the video, and certainly as you get your hands on a syringe and needles and carpules, that you'll be a little less hesitant and a little less apprehensive about delivering local anesthetic. You all have a good day, morning, afternoon, evening, and if you have any questions about the information, don't hesitate to call, text, or email.